Good evening, everybody. It's a real pleasure to be able to chair the session and to welcome you to the Insight Public Lecture tonight. My name's Andy Blamire. I'm the Dean of the Translational and Clinical Research Institute, and our speaker tonight, Professor Vijay Kunadian, is a member of the institute on which I lead. So, who is our speaker for tonight? Well, Vijay is Professor of Interventional Cardiology. She has a personal chair here at the university, but she's also an honorary academic consultant in interventional cardiology at the Freeman. So she divides her time between delivering world-leading academic research and delivering equally world-leading patient care within the NHS. She completed all of her cardiology and interventional training in the northeast of England, so she's a local person in terms of her traineeship. She then spent time undertaking an international academic fellowship, so she went over to Boston and spent time there at the Brigham and Women's Hospital at Harvard Medical School. And as a result of the work that she's done, she has an international reputation in interventional cardiology and cardiovascular research, and she's very sought after as a speaker in the city here and worldwide. So she speaks at national and international meetings on a regular basis. She's also been a champion for diversity in her speciality, acting as a role model. I've got notes here that only 5% of interventional cardiologists are female, so that puts Vijay in a significant minority, and I know we're going to hear a little bit about the challenges that you face in that role in the presentation. And only less than 1% of those clinical academic researchers are also female, so even a more minority group in terms of people in the research field. So she's also recently been awarded a UK Department of Health National Clinical Excellence Bronze Award, recognising the clinical care and her excellence in the delivery that she gives for the NHS. So she's going to speak to us tonight about breaking down the barriers in the treatment of cardiovascular disease. Vijay, good to see you.
Good evening, everybody. Thank you very much, Andy, for that very kind introduction. It really is my absolute honor and privilege to be here this morning. As Andy mentioned, I grew up in cardiology in the Northeast, in Newcastle, and to be here delivering this Insights lecture, which I have been an audience, and I looked at the previous presentations, and they're all very distinguished professors and colleagues that have given the presentation. So it really is my honor and privilege to be here. But we're going to go straight into the problem. How can we break down the barriers in the treatment of cardiovascular disease? To put things into perspective, let's forget about COVID for a bit. So I'm giving you statistics from 2019. You will see that ischemic heart disease, which is the disease of the coronary arteries, is the lead cause of death in the UK and worldwide, and everything else follows afterwards. You might just ask me, Vijay, what is ischemic heart disease? What is coronary artery disease? The arteries, which all of us have, is a tube, and then the tube has 3 layers. Over time, because of a number of risk factors, including smoking, diabetes, high blood pressure, family history, cholesterol, there's buildup of cholesterol in the wall. So you'd want the cholesterol and the calcium moving freely in the bloodstream, but they seep through the endothelium, which is dysfunctional, and they build up. So there is restriction of blood flow. So if there's restriction of blood flow in the heart, it leads to heart attacks. If it happens in the brain, it gives rise to stroke. If it happens in your leg arteries, it gives rise to peripheral vascular disease, gangrene, etc., for example. And this is what a histology looks like. You can see the wall of the artery is very much thickened, and there's a lot of cholesterol deposits in the wall of the artery. And also when it actually ruptures and there is blood clot formation and it blocks the artery completely, and that leads to the full-blown heart attack that we have. So it's pretty simple and straightforward, but I will share with you what are the challenges we are facing and why we still haven't conquered the heart disease as yet. So what does a heart attack looks like? As Andy mentioned, I work at the Freeman Hospital, one of the largest heart attack centers in the country. This is one of my patients. And when patients come in with a full-blown heart attack, the arteries, as I mentioned, they are like tubes. They should be fully open. And you can see the main blood vessel of the heart is completely blocked. So it's life-threatening. This patient came to us unconscious. When we open the artery, you can see the full artery nice and fully open, and the patient survived because she was just literally living at the back of Freeman Hospital. Within 5 minutes, the ambulance brought over to us, and we were able to save her life. And as I mentioned, this is the latest statistics. I showed you the 2019 statistics. This is 2022 statistics. Again, the bars in orange or pink is ischemic heart disease, is the coronary artery disease. And you can see I'm showing statistics for the Western Europe. You can see United Kingdom is still very much high. One thing I'd like to point out, and this is something that really opened my eyes in a couple of years with me working on a major commission to reduce the global burden of heart disease, is that I'm sure many of you in the room have this condition, is hypertension. We've known about hypertension for a very long time, but believe it or not, hypertension is the most undiagnosed and undertreated condition, and that's one of the primary driver for the coronary artery disease. This is the statistics that the British Heart Foundation provides, which started in the 60s. You can see that there has been a reduction in the mortality, both among men and women, over the years. And still, that's because of the development progress that we have in pharmacotherapy, which is medications, as well as the interventional strategies that we provide. But this is the latest statistics that I again obtained from the British Heart Foundation website. The diseases of the heart and circulatory system, as highlighted at the top, is still the most common condition. In England and Wales alone 85,100 heart attack admissions happen, and about 40% of them are full-blown heart attack, and the remain is a minor heart attack. And as you can see in the chart above, that as people get older, and this is one of my areas of interest that I have developed over the last decade, is as people grow older, the minor heart attack occurrence is more frequent. And I also want to highlight the regional variation. I know that we have a number of regional variation, a number of aspects of life, but relating to cardiovascular disease, the darker the color on the map here that I have shown, again, statistics from the British Heart Foundation, the higher the age standardized death rates due to diseases of heart and circulatory system. So you can see down below in the great town of London, it's a little bit pink, meaning the death rates are much lower. But when we go higher up, north of England, Scotland, it's still very high. And that's something that I'm really very passionate about. Why do we have so much heart disease burden that I see actually when I'm looking after patients on the wards as well, which is reflected in the statistics that we have. One other thing, as Andy mentioned, I've been here pretty much leaving medical school, and when I trained to do these procedures, or when I was doing ward rounds in CCU, I never saw, for example, an 85 or 95-year-old patient on coronary care unit, or in the cardiac catheterization laboratory, or even undergoing surgery. But when I became a consultant some 12 years ago, pretty much every one of my patients were born in the 1930s. So I thought maybe the staff are doing some kind of prank on me, because the week before I was a registrar, now I'm a consultant. And the staff told me, actually, Vijay, that is your list. I had about 10 patients in their 80s. And that's a real phenomenon. And that's because our population is aging. People are living longer. We are surviving a number of other conditions, surviving cancer, surviving stroke, surviving COPD, and then heart disease catches up with that. But again, I'll talk a little bit more about that in great detail. Not only is the aging the challenge, but also the multimorbidity. And in addition to just being older, there's other phenomena such as frailty and other coexisting illness that comes with these older adults when they present with heart attack, for example. So in the UK, so I'm interventional cardiologist, so I go through the wrist or through the groin to unblock blocked arteries. In the UK, there's around 100,000 procedures get performed, and coronary artery bypass surgery has plateaued over the years. And one thing I wanted to highlight again, because of the the diversity, etc. And, Freeman Hospital is highlighted there. Up until just before the pandemic, we were the highest volume per operator, so meaning I would do twice the national average procedure when compared to somebody else in another town, for example, in the UK. And again, as Andy mentioned, the representation, there's 713 male interventional cardiologists, but only 41, and I was one of them. And again, all the other statistics that I have shown here has already been highlighted. So, and the number of procedures that we do in older adults is also increasing as the age progresses. And there are challenges with dealing with coronary arteries in older adults. Many times, when I'm doing a procedure on a Monday afternoon, so I could be doing procedure 6, 7 o'clock in the evening, there will be a patient, okay, this will be an easy one, but it never is an easy one because of the complexity of the coronary arteries and the calcification that occurs. And also the challenges of repeat hospitalization for repeat procedures, and of course the cost to the providers. And these are sort of the patient that we get referred, 91-year-old with multiple comorbidities, and they're having ECG changes and chest pain. Do you want to take them to the cath lab to address these, to fix the coronary artery, for example? And then 80-year-old female with multiple comorbidities, 86-year-old. I'm showing all of these because I thought there will be an easy one, but it took 2 hours literally to finish each of the cases. In some cases, because every patient now, when they call for ambulance, they get brought to the heart attack center. They have, as is mentioned, instead of being a smooth tube, they have a lot of blockages. As heroic as we are in terms of unblocking the blocked arteries, but we need to make a decision that is suitable, individualized for the patient. So in this case, in many of the cases, it's best treating patients with conservative treatment, doing no harm, than taking out all the potential kits that we have available in the catheter laboratory in order to deal with these patients. So I was very surprised myself. I'm not showing this to brag on myself, but also to encourage any female juniors in the audience. You get on with your job and do it. And then I was very surprised to receive this letter from our national body that I had better than expected survival for my patients despite the complexity of cases that we were treating. And I also, as Andy mentioned, very delighted to receive the National Clinical Excellence Award for the care that we provide. And again, very few women are represented in these award categories. And I just want to highlight that if you really work hard and do your best, then your work will be rewarded, whether you're a man or a woman, for example. That has been my experience. So now back to our management of heart disease in older adults. More than half of the heart attacks happens in patients who are 70 years of age or over. And a lot of these older adults die from coronary artery disease than younger people. But one of the striking analysis is this one, where as people grow older, the basic treatment, including aspirin, statin, angiography, are grossly underprescribed in older people. Is that evidence-based or is it biased? I will talk about it in a bit more in detail as we go further. And as I mentioned, the frailty phenomenon, so somebody who's 85, and I have seen this, might look like a 65-year-old, and a 65-year-old might look like an 85-year-old. That's where the frailty and the comorbidity issue comes on. So when you look at the same age patient, and if they are frail, their chances of survival following a heart attack is significantly reduced, or the mortality rate is much higher when compared to somebody who was robust at the same age. What about the representation? So when I was seeing all these patients in our department coming through, what is the evidence for the management of these older adults? Not much really, because there's only 14% of clinical trial participants are older adults. So we were literally practicing medicine with very little evidence in the management of heart disease in older adults. And this hasn't really picked up that much over the years, and even now the latest figures show the same. So clearly, we're dealing with more and more older adults presenting with heart attacks, and that is the biggest burden of health burden in older people. And the mortality burden is very high and other comorbidities, but there isn't very much evidence. So again, the guidelines, they say do whatever you do for the younger people, and it's not really very comprehensive in terms of suggesting evidence-based suggestion on the best care of older people with heart disease. Which is why when I took a risk of rather than taking on an NHS position, which is what I always want to do, but university offered me the academic position, I thought I'll give it a go. And then after I settled in the job for about 3 months, then my director back then asked me, Vijay, what exactly is it that you want to do your research on? And I said, it looks like we have a problem now, and we're seeing a lot of older people with heart disease. And then when I mentioned that to him, his face lit up. And then perfect, because we have in Newcastle, NIH, our Biomedical Research Center in Aging, and your work will fit in with us very nicely. And at the time, some 10 years ago, I was given £150,000 grant award from the BRC to do this study called ICON-1 study, which really addressed a lot of it's very amazing because it's such a big problem, but nobody actually researched that, nobody's actually studied that ever. And we first of all demonstrated that we can recruit older adults into research, because often people have a number of reasons why older adults are not being recruited into clinical studies. One of them because they don't want to participate, etc. But we managed to recruit 300 patients. And we found a number of very interesting findings. And as I mentioned earlier on, I really wanted to know, am I doing the right thing for my patient? Which patient should I be really aggressive in the way that we do our procedures, and which patient we should really keep them comfortable, making sure that we're not causing them any harm. And again, our study showed that if you are robust, then you have better survival over a course of time, but certainly if you're frail, then your outcome is much lower. And the other important thing, again, me being a cardiologist and looking at cognition, we found 48% of patients that came through our door for heart procedures had undiagnosed cognitive impairment, and 35% experienced cognitive decline over the next 12 months. And the people that had cognitive impairment, this is the results from 1 year. I think one of my fellows is in the audience, and she looked at the data for 5 years. If you're cognitively impaired and if you have heart attack, then your outcome is much worse when compared to somebody with normal cognition. So it really is giving us the understanding of what's happening in our older adults, so that we can intervene to improve the quality of life as well as reduce mortality in our older adults. And we also, because I wanted to know, is the pattern of coronary artery disease different in older adults or frail adults compared to robust? And we found that frailty was associated with high-risk plaque. These are the high-risk plaques. And you remember in the cartoon that I showed, there is a tendency for the plaque to rupture. So these older, frail patients, they had a lot of these plaques that were more likely to rupture when compared to robust individuals, for example. And again, gives us the potential to treat these plaques that could rupture and gives rise to a heart attack. And then the angiographic parameters, the heart arteries, frail patients have more adverse heart artery patterns, including calcification, and that might directly lead to poor outcomes in these people. And the quality of life, again, if you're frail in the same age, your quality of life is likely to be lower when compared to robust people. But one thing that we found out, one of my fellows who did this study, is that when I did a survey across the UK asking why are not older people getting the same kind of treatment compared to younger individuals, people said, oh, they're at risk of complications, or there is no futility. But what we found is that when we actually do these angiography and interventional procedures to treat the condition, then their quality of life is much improved when compared to people not receiving invasive procedure, for example. And again, we followed the patients up until 5 years, which again confirmed that if you are robust, and if you've sustained a heart attack, then your outcomes are much better when compared to people that are frail. And comorbidities, again, if you have same age group, but if you have multiple comorbidities over a course of time, then they are less likely to survive when compared to people with less comorbidity. And all of these information are really key vital, one, for us as doctors looking after these patients, as well as for the patients themselves, because we can clearly provide a management strategy, individualize the care, appropriate for that particular patient rather than using a blanketed approach for every patient. And again, I will be touching on the women and heart disease in my next part of the presentation. One thing, again, this is a recent finding from one of my fellows, is that when we give the same treatment to both men and women in terms of angiography or intervention or medical therapy, then there's no difference in terms of outcome between men and women. So you will see that this is very simple question, is something that we saw in the clinic, and we saw it as a need, and with the help of support from our BRC, we were able to find so many interesting findings, which has not been evaluated anywhere else in the world, believe it or not. And I was very surprised to see that our findings were highlighted in the 2020 European Society of Cardiology guidelines in the management of acute coronary syndrome in patients with non-ST elevation MI, which is the minor heart attack. And more recently, all of our work that I have just shown you is being included in the American Heart Association management of acute coronary syndrome in older population as scientific statements. So really our work is reaching, impacting practice worldwide. So what about, so everything that we do, again, I showed you earlier on, only 12 to 14% of older patients are represented in clinical trials. And ST-ACS stands for minor heart attack, non-ST elevation myocardial infarction. There isn't, so most of the study, the mean age, as you can see, is 62, 66, 62 years of age. So how can we imply the same findings in a 62-year-old to somebody who's 85 or even 90? My oldest patient that I did procedure on is 98 years of age. So there is clearly a lack of evidence. And there are 5 different groups at the bottom of the slide. Italian, after 80 comes from Norway, Mosca comes from Spain, Herlicker is Sweden, Wrinkle is Great Britain. You can see the number of patients represented in this study. I think that might be in my next slide. There's only 313 patients, after 80, 457, Mosca 106, etc. As you can see, most of the studies that we have influencing daily practice consists of patient participation of at least 15 to 20,000. But in the management of the most common condition in older adults, the overall sample size that we have in terms of guiding management is 1,313. And again, just to emphasize again the limitation of older studies and the newer studies. And the newer studies, why there's only 1,300 patients recruited? Because of the recruitment problems, most studies are underpowered because you can't really gain an answer one way or the other. And the endpoints of the studies vary from one study to another, and none of the studies actually measured frailty or comorbidity. So the guideline in the UK, we have NICE, internationally you have the European Society of Cardiology, American Heart Association, really lack high quality evidence. And thus, it leads to undertreatment. And then, of course, I showed you that older adults have higher baseline risk and ultimately lead to poor outcomes. So the overall problem for us, NHS, economy, and global burden, underrepresentation of older adults in clinical studies. The studies that we have, mean age is around 62 years of age. Advanced care, including pharmacotherapy medications and interventional procedures, are underutilized in older patients. Frail patients, comorbid patients, and cognitively impaired have constantly been excluded or neglected in clinical research. which is the reason, with the help of the pilot data that we gathered from our NIHR BRC-funded ICON-1 study, we generated the pilot data and convinced the Great British Heart Foundation to give us the funding for the Seniorita trial. And we faced all of the challenges that I just explained to you, recruitment problems and people not wanting to participate, and also the participation of research varied across the nation. But it's great to know that we have the largest recruitment coming from the north of England. So I showed you the overall evidence that we have so far is 1,300, but in Seniorita to date we have 1,505 patients recruited, making it the world's largest clinical trial addressing the unmet need in the management of older patients with heart disease. Our study will definitely impact guidelines, change practice, and hopefully will provide better guidance on the management of the most common condition in our older people. And we're recruiting patients from 52 NHS sites, and the recruitment is due to close at the end of in March. So again, I'm not saying this to brag about myself, because I'm minority 5% in interventional cardiology and less than 1% in academia. It really is brilliant to receive. And these dots here, this is a map coming from the British Heart Foundation. The larger the circle is the larger the amount of money that the BHF funds. So you can see that although the burden of heart disease is much higher in the north and in Scotland, the largest amount of funding goes to London. And here I've pointed out the funding that comes from the BHF to Newcastle. So that's one of the underrepresented cohort of population. And as I was working through the older adults and looking at the unmet need, the other big theme that emerged is how women are so underrepresented in cardiovascular research. And again, I'm showing you an example of one of my patients. This is a 35-year-old lady, came down from Sunderland. She's very happy for me to share her story. She presented 6 days after sustaining a heart attack. So she had symptoms, I think on Sunday, and then she thought it was nothing and she put it off. And she went to the GP, and GP said, listened to her chest because she was a smoker and she had a lot of noise in her chest, and he gave her amoxicillin thinking it was chest infection. And then it didn't go away. And then 2 days later, she went again back to the GP, and then he gave her indigestion medication. And then the following day, on Thursday, sister looked at her and said, "You're not looking right. I'm going to call the ambulance." And the ambulance comes along, and of course they do the ECG. It's a full-blown heart attack. And they said, "We're going to take you straight to Freeman." And I was on call that Friday, and you can see that she has a blocked artery right there. She was very lucky that after 5 days, she survived, because a lot of people, after sustaining a major heart attack, don't make it to hospital, and we open up a artery, and she remains well to this day. So it's lack of awareness among physicians as well as among the patients themselves, that heart disease is the lead cause of death in women worldwide. And the other aspect is women tend to think that they want to put their family first. So if they're having any symptom, they're not the first ones to get help. And this is one of my other patients, 46-year-old, had bad pain, chest pain around Christmas, but she wanted to focus on Christmas and family and everything. She didn't call for help. Continued to have pain for 7 months. Again, she's been so lucky. Went to one of our neighboring hospitals, and they found changes on her MRI scan, referred to her. Of course, when she came again, I was on call that day. She had a blocked artery. So again, lack of awareness among women, and thankfully she also had her artery open, and she's doing well, but not very many people are lucky in that instance. So this is focusing on women and heart disease. Cardiovascular disease is the lead cause of mortality in women globally. A lot of people tend to think it's something else, and sometimes it's maybe breast cancer or cervical cancer, but actually it is ischemic heart disease. 35% of all deaths in women worldwide is caused by cardiovascular disease. One thing for me as a doctor looking after these patients, cardiovascular disease most of the time is preventable. And we need people to come to us at a stage where we're able to prevent them. So 275 million women's lives were diagnosed with cardiovascular disease, and nearly 9 million women lost their lives, which could have been prevented. And I mentioned about all of the older adults being understudied and underrepresented in clinical trials. This is massive. Cardiovascular disease among women, this also includes young women, understudied, under-recognized, under-diagnosed, undertreated, and women are underrepresented in clinical trials. So again, breaking down by the mortality rates in women, again, for women, diseases of the heart and circulatory system is the lead cause of death. Awareness that heart disease is the lead cause of death had actually declined. So a lot of women tend to think it's actually cancer that's the biggest killer. So they're very quick to get help in that area. But while it is hard, like I gave you the examples of 2 of my patients, it gets ignored. And then, of course, they come to us with consequences. This number that I have shown is slightly higher, but a lot of clinical research, but like the older adults, are very grossly underrepresented. Most of the heart attack studies, about 25% of people represented are women, 75% are women. But there are a lot of differences, of course, we know in the pathophysiology of women and heart disease, which I will discuss in a little bit more in detail. So in the last decade or so, we're also seeing an increase in heart attacks in young women in their 30s and 40s. It could be because we're having a lot more advanced diagnostics that we're picking up, or it could be a real thing that these are happening. And the other thing that, again, that I'm really focusing on, I did focus on it 10 years ago, but there's only so many hours in the day. In fact, we wrote a paper some 10 years ago together with our obstetrics and gynecology colleagues, which was published in JACC, highlighting the importance. I mentioned to you the risk factors specific for development of coronary artery disease, which is diabetes, smoking, high blood pressure, cholesterol, etc. Women, on top of that, have additional factors. So I see a lot of women in the room here. So if you experience, when you're, say, a woman gets pregnant in their late 20s or early 30s, and they experience preeclampsia and the baby is born, the preeclampsia is completely forgotten about. We're beginning to learn that there are a number of studies that if you have preeclampsia, gestational diabetes, those women are at higher risk of developing heart attacks or even decreased survival down the line. Menopause, estrogen protects the inner lining of the artery, and when women experience menopause, there is an increase in cardiovascular disease. And again, that's something has not been addressed so far, which really we're working to address. And a number of gynecological conditions, as I have listed here in a European consensus document that I had a privilege to be part of, highlighting these important risk factors associated with female patients. Women also, in one of the analysis from a trial that I was involved in, women also tend to bleed a lot more following, so when somebody has a heart attack, blood thinners is what we give, and then women tend to bleed a lot more than men, for example. These are some of the important findings. The one on that right-hand side to me is a finding from the United States, which shows that women are, to this day, less likely to receive guideline-recommended therapy. So if you have a heart attack, your doctor would normally prescribe aspirin, statin, ACE inhibitor, and other medications. And all of those basic medications following a heart attack in women are underprescribed. And then it hit home to me when an analysis from the UK, England and Wales National Heart Attack Database showed similar findings that pretty much all of the treatment that we provide in the management of patients with heart attacks are grossly underprescribed. So you might say, so what, Vijay? But that actually directly translates into reduced survival for women when compared to men. So women survive less following a heart disease when compared to men. That started to bother me. And I did another analysis looking at our UK BCIS, British Cardiovascular Intervention Society database, and I showed exactly the same. So after we did an angioplasty stent procedure, women survive less when compared to men. So we started asking questions why, and there are a number of initiatives that we are doing both nationally and internationally, to address all of that. And of course, over the pandemic, the socioeconomic status really amplified the disparities that we have. And this is the map of England and Wales. The darker the color is, the higher the deprivation. So women get more worse affected than men living in the low socioeconomic status. So hence, during the pandemic, one of our medical students, both of them, Jeremy and Ben, wrote this paper, how women are worse affected if they were to live in a socially deprived area. And that's because of the aggravation of the risk factors that's already there. And that directly leads to poor outcomes in women, for example. So even before the pandemic, the Lancet realized this as an important health issue, and they launched a commission, Lancet Commission, to reduce the global burden of heart disease in women by 2030. And I was invited to be the UK commissioner, and that really opened my eyes, because working in the north of England, you're just looking at things that are happening in and around you, but it really helped us to see things on a global scale. And that's where, because of these underrepresentation and the unwanted loss of life that we are seeing due to cardiovascular disease, our mission is to reduce the global burden of heart disease in women by 2030, promote cardiovascular health and improve outcomes for women worldwide, identify the gaps, where are we going wrong, and some I have already highlighted, and how can we address the areas that are unmet in order to reduce this burden. And more importantly, increase the awareness. And a lot of my patients come and tell me, I didn't realize that I could be having a heart attack. And also among clinicians, we were doing a number of initiatives to raise the global awareness. And this is something that we have presented in the commission. As such, there are a number of opportunities to intervene to improve the cardiovascular outcome in a female patient. As I mentioned, the pregnancy, adulthood is the key thing where we probably have not worked on very well so far, that we really want to address all throughout the to old age. So there are a number of key recommendations on different key disease areas. It could be arrhythmias, it could be heart failure, but I worked on the acute coronary syndrome, which is heart attacks. And some of the areas that we identified, I mentioned to you that heart attack is caused by blocked arteries. But heart attacks can also happen when the arteries are open, and there are a number of reasons. And one of them is called as INOCA, which is ischemia with non-obstructive coronary arteries happening in the stable setting. And MINOCA is myocardial infarction with non-obstructive coronary arteries. So in the past, I've done that myself, or probably been in an environment when we see a normal artery, when patients come in with a heart attack, we'll say, nothing wrong with you, I'm going to discharge you back to the GP. But we're understanding that when a female patient, or male, for example, present with a heart attack, and if they have open arteries, there are a number of other conditions that we need to be thinking about. And there are other conditions like spontaneous coronary artery dissection, which is a tear on the inner lining of the artery, which may not be directly related to the buildup of cholesterol in the wall of the artery. So in order to address the INOCA problem, actually during the pandemic, when we were all shut down, and as part of the European group, European Association of Percutaneous Cardiovascular Intervention, that I'm a member of, we wrote this consensus document, how to improve, how to diagnose and treat the patients with non-obstructive coronary arteries, and yet they are presenting with heart problem. And that really raised the awareness of this particular condition worldwide. It's very interesting to know how this has been there for a long time, but only now we've come to the point of raising the awareness. But at least we've done that. We were able to raise the awareness, and a number of research activities now that we're able to travel out and about. And when I go abroad, people come and say, thank you for this document, and we're doing this to address our population, etc. So it's targeting one or two the areas, so we can, with combined effort, that we can improve the overall cardiovascular disease burden for our patients. But again, the management of heart disease is pretty simple, in my view. All you need to do is lifestyle on the top, factor, and I tell my patients if you do exercise, it's like taking 5 tablets, because it does all of the things that your exercise, your tablets does if you exercise. And then again, treating the risk factors, blood pressure, cholesterol, diabetes, etc. And then identifying the right diagnosis and providing the right treatment, because the medication that we give for different conditions can be different. Then I'll just touch upon the MINOCA, which is heart attack with unblocked or non-obstructed arteries. As I said, when a patient get brought to the cath lab with ECG changes and heart enzyme rise, when we see open artery, a bit like this, normally what we would do is, nothing wrong with you, I'm going to send you home. But we're learning more that this condition is not a benign one, it needs treatment. So working in the Freeman Hospital, I get, if I'm on call, or any of my other colleagues doing this procedure get a call, we get called from pretty much all of these settings, as long as there is an ECG change and maybe raised blood test. But not always we see the blocked arteries that I described earlier on. And there could be a number of reasons. Number one reason is the plaque rupture. So it may not be visible all that clearly on the angiogram when we do it, but it's the plaque rupture and buildup of cholesterol that may not be as significant enough to cause visual obstruction in the coronary arteries, meaning that we need to provide the same treatment that we give for the blocked arteries to these people that also come in with these plaque rupture and erosion. And I've listed a number of other conditions, but I'll quickly go through them just to show some examples. There are other conditions. So living in the north of England, viral myocarditis, and now we had COVID. COVID can cause myocarditis. All these patients can present to us with like a full-blown heart attack, for example. Stress, again, for women in particular, if you have high mental stress, there's excess release of adrenaline, and that leads to a condition called as Takotsubo cardiomyopathy, which is a ballooning syndrome. The heart literally balloons out. And that happens, we see it more often in women when compared to men, for example. And there are other reasons, and I have dealt with all of these. A patient can look like as if they are presenting with a heart attack, but they probably have pulmonary embolism or had a bleed in the brain, which is why it's really important to take the history to make sure that we're treating the right condition. Some of the examples of the patients that we have dealt with, I won't go in great detail, but you can see in this patient, she has a haziness there. That is a blood clot. As soon as we suck the blood clot out, everything looked completely normal. Then you're wondering, where did the blood clot come from? But common things are common. When we put a camera into it and had a look at the artery, it was actually a rupture of the plaque that resulted in that blood clot formation. So again, this is a female patient. She didn't get help in a timely manner, but she came in the end. We did all of the right things, going above and beyond, and we were able to stent that lesion, and she survived. And the other spontaneous coronary artery dissection is, this is again one of my patients where there's a tear on the inside of the artery. And again, this happens more often in female patients. Again, this has been underdiagnosed and undertreated for a very long time, but we're now, through many research, we're able to identify the right treatment and the right diagnostic approaches. This is a patient, again, presented to us like a heart attack, but unfortunately, when we connected him to the blood pressure measuring, his blood pressure was 180, and he didn't know that he had blood pressure for a long time. So his high blood pressure, in fact, resulted in what we call as the aortic dissection. So it was a tear in the entire aorta, all from the root to his legs. So had his blood pressure been diagnosed correctly and he received the treatment, this would have been avoided. But then anyway, our amazing surgeons did fantastic work and fixed everything. And I also fixed his blocked artery where there was a tear going into it. But this is preventable, as you can see, and the patient continues to remain well. So myocarditis, working in a transplant center, again, these people also can present with a lot of ECG changes, but when we do an angiogram, it's completely normal. And that's because the patient, this particular patient, I think, was a transplant rejection, but presented as a heart attack. We also see a number of unusual cases. So this was 5 minutes, 8 o'clock, 5 to 8 on a Monday. I was about to finish. I wasn't on call overnight, and the staff tell me, Vijay, there's a heart attack patient just arrived. Instead of calling, he's only 35 or something, so it's going to be a really quick one. And then I go ahead and do the case, and usually it will be a quick one. It literally takes 30 minutes to do the procedure. But even after 2 hours, I just could not get that artery opened up. And one thinking, why did I should have handed over to my night colleague? But I was very curious. But in the end, we managed to get the clot out from the artery. You can see there's a blocked artery there, a lot of stuff being extracted. But this patient has got a clotting disorder that made the arteries to clot, arteries and veins to clot. So not always it's the plaque rupture that causes heart attack, but also other conditions. Coronary artery spasm, you can see she has a nice clear artery, and then our artery goes into spasm like that. And a lot of people think that coronary spasm is quite a benign condition, but this lady actually presented with a cardiac arrest, needing a defibrillator to prevent her from having cardiac arrest afterwards. So this is a recent analysis that one of my fellows did, comparing the blocked arteries and the MINOCA. And here what we're seeing is that there is no difference in the mortality between patients that present with blocked artery and the non-obstructed artery, meaning we need to take both of them seriously and ensure that our patients receive the right treatment. Again, a number of recommendations we make from this Lancet Commission. If you're interested, please do read them, but I will quickly go through them so we have plenty of time for questions afterwards. And this is, again, what do we do next? I can't come back in the next 10 years and still say women are underrepresented and women still are dying as a result of underdiagnosis and undertreatment. So we're looking at a number of ways how we can address that. And again, here I'm highlighting the percentage of women represented in clinical trials. And that's something that we're working on to maybe as a next clinical trial to recruit patients. But then again, recruiting women into clinical trials is a real challenge. If you're recruiting young women, they say, I have to look after my kids, and a number of reasons. And again, in our commission, without research, we cannot find the best treatment. So in our commission, we provide a number of strategies to increase the proportion of women in clinical trials. So in addition to all of the work, just to bring my talk to a conclusion, the ones highlighted in purple, in addition to our own studies, we also do studies participating in international studies in collaboration with a major cardiovascular research institution, because we do need to collaborate worldwide, because it's not just a Northeast problem, it's a worldwide problem. And also, because of all the work that we do, also get privilege and opportunity to participate in the executive committees of national and international cardiac societies. In addition, for me, I think the work over the years, it's the privilege of working with many of our junior colleagues who have been involved in my research team and gone on to do great things either as consultant cardiologists or as academics. So I hope I have been able to convince you that cardiovascular disease is a major health problem. Now really is the time for us to act and intervene. There are a number of unanswered questions, and it's really important that we give precedence to enrolling such neglected patients in clinical research to inform and impact guidelines. So I never run out of work to do. There is still plenty of work for us to do in order to reduce the global burden of heart disease. I thank you very much for your attention.